Advancing health equity requires examining the history of genetics. We are going to hear from Vence Bonham, the Acting Deputy Director and Associate Investigator of the National Human Genome Research Institute, National Institutes of Health, and he is a pre-recorded presenter today. Joining him live after this pre-recording will be Dr. Christopher Donohue, who is the historian at the National Human Genome Research Institute at the National Institutes of Health.
Thank you for the invitation to speak at this year's Mountain States Regional Genetics Network Summit. I had wished to participate live in this virtual meeting. Unfortunately, my schedule required that I pre-record my talk. I'm pleased that my colleague, Dr. Christopher Donohue, the NHGRI historian, is able to join you today and to comment on my talk and reflect on the topic of advancing health equity by examining the history of genetics. As a historian, he is able to discuss the history of the field of genetics and genomics. The learning objectives of this talk are to, one, define eugenics, scientific racism, and other ideologies that impact the field of genetics. And second, to explain how eugenics may be seen by some scholars and the public as still existing in this decade. But my talk is also framed in the broad concept of health equity and how do we advance health equity within the field of genetics and genomics. The CDC defines health equity as when every person has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. This framework for equity challenges us to recognize the barriers that patients and families have to attain the full health potential. For our discussion today and the work at the National Human Genome Research Institute, we put a genomic lens on the definition of health equity, which includes access to genetic and genomic testing, access to high quality and comprehensive genomic information, development of accessible genomic technologies and methods, and quality treatment and management of genetic and genomic findings. And finally, acceptability of genetic and genomic approaches and interventions within clinical care. I argue that advancing health equity requires our reckoning with the history of genetics. There are many examples of misdeeds, bogus theories, and racist individuals in the history of genetics. And I'm only going to examine the tip of the iceberg. Francis Galton, an English statistician, demographer, and ethnologist, and cousin of Charles Darwin, coined the term eugenics in 1883. Galton defined eugenics as the study of agencies under social control that may improve or impair the racial qualities of future generations, either physically or mentally. Here in the slide that I'm showing you today is the National Human Genome Research Institute has a genetic glossary where we define a number of genetic and genomic concepts, including eugenics. In the NHGRI glossary, we define eugenics as the discredited belief that selective breeding for certain inherited human traits can improve the fitness of future generations. For eugenicists, fitness corresponds to a narrow view of humanity and society that developed directly from the ideologies and practices of scientific racism, colonialism, ableism, and imperialism. I'm pleased that the National Human Genome Research Institute's Communications Office and our History of Genomics program, led by Dr. Christopher Donohue, has been leading within the genomics community a dialogue on the meaning of eugenics, historical and present-day discussions of eugenics and scientific racism. NHGRI has brought together some of the leading international scholars in these discussions. The two-day symposium was held in December of 2021 and is available online. It is a great resource for your students and staff examining the myths of eugenics, sterilization in the United States, and experiences of legacy of eugenics in slavery and in the history of our country and globally, with an important discussion of legacy of eugenics today. The history of eugenics and sterilization in the United States may surprise some. It is not limited to the states that today would be considered southern states or more conservative states. North Carolina is reckoning with its history of state-led sterilization of more than 7,600 people between 1933 and 1973. And the law remained effective until 1973, when the last recorded sterilization was performed under the Act. In 2003, the North Carolina Senate voted unanimously to overturn the 74-year-old eugenics law. Some of those sterilized by coercion or force are receiving some payments with regards to the experiences that they had at the basic of the state. The history of eugenic sterilization in North Carolina is just beginning to be told. I would refer you to the National Public Radio story that's cited on this slide. More than 20,000 people were sterilized in the state of California prior to 1979. California has been by far one of the highest states for the number of sterilizations in the United States. California civic leaders had helped popularize eugenics, not just in the state of California, but across the world, including Nazi Germany. History of eugenics is tied to ableism of today. And the National Human Genome Research Institute and the State University of New York at Buffalo's Center for Disability Studies held a two-day symposium entitled Irreducible Subjects, Disability and Genomics in the Past, Present, and Future. The symposium addressed historical and present-day constructions of disability and ableism in the context of genetics and genomics. I encourage you to ask my colleague, Dr. Donohue, questions about this workshop that was held this year. We cannot talk about eugenics and scientific and structural inequities in health without talking about scientific racism. And again, NHGRI has a definition within the genetic glossary of scientific racism. We define it as the historical patterns of ideologies that generate pseudoscientific racist beliefs, that perpetually influences racial biases, discrimination in science and research, and leading scientists across scientific institutions in the 19th and early 20th century were proponents of such ideologies. By the mid-20th century, pseudoscientific racist beliefs were widely disproven by many within the field of genetics and genomics. However, evidence shows that scientific racism persists in science and research today. Our country is recognizing and facing the issues with regards to racism and medicine and science. And I just refer you to this New York Times article published by Linda Valrosa, where she focused on the myths about physical racial differences that were used to justify slavery that are still part of medicine today. The infamous study of deception in research started out as a study to understand Black-white differences in syphilis. Dr. J.E. Moore, nation's leading venereal oncologist, wrote to Dr. Clark, then chief of the U.S. Public Health Service of Venereal Disease Clinic in 1933 regarding the U.S. Public Health Service syphilis study. As you know, this study did not end until 1972 and continues to be a shadow on biomedical research today. This article in 1966, Ebony magazine, which is a magazine that's been targeted for decades for African American and Black communities, describes the, quote, Negro disease. This conversation was not just in the lay media, but in clinical and scientific literature. A 1922 JAMA article talked about sickle cell disease as a racial disease. As quoted, up to the present, the malady has been seen only in the Negro, and so far could be ascertained it is the only disease peculiar to that race. The belief that genetic conditions are limited to one racial group continued to be part of the scientific discourse and continues actually today. But you see here in this 1947 article in JAMA where it says the most significant feature of sickle cell anemia is the fact that it is apparently the only known disease that is completely confined to a single race. We must address the narrow views with regards to understanding of genetic variation and communicating messages about genetics and race. Today, we are reckoning with the appropriateness of race and genetics. This slide is an example of a number of articles within the 2018-29 period with regards to race and genetics. And I want to thank Professor Alice Popejoy for the slide. Genetics has become intertwined in racism in the United States. I refer everyone to this October 17th, 2018 article by Amy Harmon in the New York Times about white supremacists' use of genetic studies to support their claims of racial differences and hierarchy. This year, in 2022, the shooter in Buffalo's mass murder used genetics research to justify his murder of Black people. Scholars Mildred Cho and Sandra Sujin Lee stated in a blog, "We condemn the ongoing propagation of eugenic thinking and the weaponization of genetics research, the misrepresentation of genetics research findings to justify beliefs in racial hierarchy, and who belongs in the U.S. must not go unchallenged." At that time, the American Society of Human Genetics published a statement here. The human genetics community is appalled at the news that the shooters and the hate-fueled mass killing in Buffalo rooted his racist beliefs by misusing and misrepresenting the science we strive to advance each day. As we have in 2018 and again in 2020, the human genetics community rejects in the strongest possible terms any attempt to twist and warp genetic knowledge to advance bogus racist ideologies or try to legitimize through science the fundamental hatred that forms white supremacy's evil core. We must address and deal with the ideology of white supremacy and its relationship to genetics and genomics. The field of genetics and genomics must always be thoughtful how race and ethnicity are used in the field and in our publications. In 2018 article, after geneticists made a statement about race and genetics that was clearly misunderstood, a number of scientists responded with this statement. Precisely because the problems of race are complex, scientists need to engage these issues with greater care and sophistication. Geneticists should work in collaboration with their social science and humanity colleagues to make certain that their biomedical discoveries make a positive difference in healthcare, including the care of those studied. The scientific community has long debated the use of population descriptors in research. And I'm pleased to announce that the National Institutes of Health has sponsored the National Academies of Science, Engineering, and Medicine to conduct a consensus study that will provide guidance on the use of race, ethnicity, and genetic ancestry in genetics and genomics research. 14 NIH institutes, centers, and offices and programs came together to co-sponsor the National Academy's consensus study. Over the course of the study period, the National Academies has hosted 3 public meetings and facilitated dialogue on capture input. The final report is expected to be released in March of 2023. So, does reproductive genetic technologies, genetic therapies, and new genetic testing approaches encourage modern-day eugenics? What can we as a field of science and medicine do to be conscious of the potential to promote eugenics in genetic technologies today? If it's PGD or non-invasive prenatal testing or gene editing, either somatic or germline, are these issues important for us to discuss and consider with regards to eugenics in the 21st century? As we focus on clinical practice in genetics and genomics, I argue that the guiding light must be trustworthiness of the researcher and the healthcare provider and the institutions in which they work. Trust remains the cornerstone of the patient-provider relationship, and the importance of this bond cannot be understated. It often predicts the willingness of a patient to seek care, share confidential information, comply with treatment regimens, and to participate in biomedical research. My scholar, Derek Griffin, who's a colleague of mine, defines trustworthiness as a commonly recognized antecedent to trust, and can be described as the perception of probabilities or expectation that a trusting relationship will result in gains and or losses from engaging in an encounter that requires trust, that is, risk and uncertainty and interdependence. Trustworthiness begets trust by giving patients a reason to trust, Professor Griffin stated. In a commentary I published with a research fellow in my research group several years ago, we stated, while physicians carry incredible potential to serve as agents and mediators of trust between patients and research institutions, there are potential impediments that may undermine this process if not considered carefully. So I argue that we must explore the issues of trust and trustworthiness when we think about and examine the history of eugenics and examine the history with regards to genetics, and then look at today and how we treat diverse populations in our clinics, in our country, and in our society, and how do we make sure that the benefits of genetics and genomics truly benefit all populations. So how do we enhance health equity and move beyond history of genetics? I believe it's essential that we change the workforce within the field. The National Human Genome Research Institute has identified as a fundamental value and principle of the field to champion a diverse genomic workforce. We state the promise of genomics cannot be fully achieved without attracting, developing, and retaining a diverse workforce, which includes individuals from groups that are currently underrepresented in the genomic enterprise. NHGRI has identified fostering a diverse genomics workforce as an important area for the Institute to sustain and improve the foundation of the field of genomics. In January 2021, we published an action agenda building a diverse genomics workforce. I refer you to the plan to see the guiding goals that we have as an institute for our work to enhance the diversity of the genetic and genomic workforce. In closure, I want to focus on the need for the scientific community, the genetics and genomics community, and medicine to cultivate diversity as an ethos. My lab authored this commentary in September of 2021, where we identified that individuals, organizations, and communities must focus on diversity with intentionality, reckoning, interrogation, introspection, and reflection. I invite you to read the article and to think about your own team, organization, and professional community, and how we can continuously make the field of genetics and genomics open to a diverse workforce with the mission of providing quality healthcare and using the tools and knowledge of genetics for all patients and all families. We stated the cultivation and adoption of diversity as an ethos requires shifting our focus to being intentional about an institution's character, culture, and climate. And one way for this ethos to be sustained is by facilitating an intentional anti-racism approach within the field. So I want to thank you for the opportunity to participate in the summit and would like to introduce my colleague, Dr. Christopher Donohue, to make reflections on my comments and bring his perspective as a historian. So thank you. I wish you well for the best of your summit and look forward to engaging with you on this topic and other topics of importance to the field of genetics and genomics. Thank you.
Thank you, Vence. It is my honor to be able to comment, reflect, and answer questions in my capacity as the NHGRI's historian, as a scholar who is an expert on the history of eugenics and its past and present manifestations, on Mr. Bonham's talk for this year's Mountain States Regional Genetics Network Summit. As a word of caution, I will in my remarks make reference to and directly quote from the ideas and language of historical scientific personalities whose ideologies and ideas about genetics, medicine, and society have been rightly rejected as vulgar, racist, unscientific, unethical, and dehumanizing. And I want to make clear that as a historian of eugenics and scientific racism, I fundamentally reject these ideas, and I'm describing these ideas for this audience so that we can all better understand and combat them to bring the revolutionary benefits of genomics to everyone. To begin, I want to emphasize and expand on some of Mr. Bonham's points about eugenics, its history, and its connection to the development of genetics as a scientific inquiry in the 20th and 21st centuries. As importantly, I would also like to underscore how confronting both the history and present-day manifestations of eugenics and scientific racism is a necessary step towards developing that critical and professional scientific capacity for reflection and dialogue over difficult subjects, which will do a great deal to ensure both equity in our science and trust in its benefits. Eugenics was and remains a global movement which used and continues to utilize a wide variety of dehumanizing ideas and practices. Some eugenicists, like two of the founders of the American eugenics movement, Charles Davenport and Henry Goddard, erroneously believed that they had found consistent patterns of Mendelian inheritance for, in quotation marks, feeble-mindedness, a dehumanizing and ableist term used to describe individuals with intellectual disabilities. Eugenicists as problematically took the work of Charles Darwin and other 19th century naturalists to argue, again erroneously, that the future evolution of humanity would be only progressive and positive if the quote-unquote fittest individuals had more children than the quote-unquote less fit or the quote-unquote unfit. And the quote-unquote unfit had fewer children or none at all. Such a fundamental misreading of Darwin's account of evolution through the mechanism of natural selection was termed social Darwinism. Eugenics movements throughout the 20th century equally seized upon the burgeoning statistical sciences. The mathematician R.A. Fisher was an ardent eugenicist, demography, public health, surgery, and medicine. In the United States and elsewhere, eugenics melded with everyday political ideology and was avidly discussed in the scientific literature as the national newspaper. And as Mr. Bonham has underscored, eugenics, scientific racism, and scientific racism are indistinguishable and are both used repulsive accounts of biological and genetic, in quotation marks, races to promote ideas of hierarchy and exclusion. For eugenicists, the quote unquote fittest were Northern European in quotes, Nordic in quotes, Aryan in quotes, free from, and I am still quoting, blemish, disease, and disfigurement. Eugenicists ardently believe that those individuals should have the ability to have many children, that they should be able to work full time and without assistance, that they should serve in the armed forces, and that they should also generally be male and cisgender. In the United States, eugenicists throughout the 20th century and into the 21st misused science to argue that the future of the nation was to be found in its quote unquote biological fund of white Northern European men who possessed, in quotes, good genes, who could be expected to have 3 or more children. Again, in quotes, this was seen by eugenicists as the bare replacement. The myth of the replacement, which continues to fuel identitarian and other extreme right violence like the Buffalo Massacre, began in the early years of the 20th century. This vicious ideology contends that in the United States, the, in quotes, white race is slowly being pushed out of positions of influence and authority because of, in quotes, inferior non-European migrants. Geneticists from institutional positions such as that of Robert Cook, who for decades was the editor of the Journal of Heredity, argued that individuals of quote unquote lower IQ and non-European origin were reproducing faster than the quote higher intelligence Northern Europeans. And after the Second World War, leaders in the genetics community like Kurt Stern and Theodosius Dobzhansky, as some of you might know, or as all of you might know, was one of the architects of the modern synthesis in genetics, and sort of very much one of the scientists responsible for the development of modern genetics as a science, worried routinely about the existence of quote unquote deleterious genetic constitutions, and possessed multiple misplaced paranoias about overpopulation from the global south. Such rhetoric, often drawing from the same sources as the previous generation of eugenicists, still fuels attacks of quote unquote, you will not replace us, and vicious arguments against pluralism, equity, and social justice in the United States. Eugenics fascinated and sadly in some cases continues to fascinate the brightest scientific minds because of its mixture of pseudoscientific ideas and its utterly utopian account of the perfect society, free from disease and so-called disorder, using genetics and science more generally to rob and otherwise coerce individuals and groups of their social and reproductive autonomy and their fundamental right to an open future. And I want to further build on what Mr. Bonham discussed with regard to the very important and often misunderstood topic of the widespread support of eugenics and involuntary sterilization in the United States among the genetics community after World War II. So to be clear, eugenics and scientific racism did not, that support did not stop with the Second World War, the destruction of the Nazi racial state, and the Holocaust. And in fact, there is a very complex process that historians are just beginning to understand about how eugenics and scientific racism after the Second World War, so after 1945, responded to new developments in genetics and also fears about overpopulation and the so-called population bomb, which continued into the 1970s and 1980s. So as Mr. Bonham emphasized, support of eugenics and involuntary sterilization in the United States was widespread through the 1960s, 1970s, and even the 1980s, with involuntary sterilizations in the United States, according to some data, peaking in the 1960s. In fact, I believe it's 1962 or 1963. And it's worth emphasizing that until relatively recently, this is in my lifetime, genetic counseling was routinely referred by geneticists as quote unquote eugenic counseling. So Kurt Stern wrote in his Principles of Genetics, a genetics textbook widely used, published in 1973. So this is 1973, not 1944, 1933. And to be clear, these are Stern's words and not mine. So I'm quoting from Stern here, from his genetics textbook published in 1973. Much of the eugenic thinking in the past was based on the inadequate knowledge and prejudice Much of the eugenic thinking in the past was based on inadequate knowledge and prejudice and has been harmful. With increasing insight, wise planning will be possible in the future. Then genetic and eugenic counseling will become the foundation of man's direction of his own biological evolution. Although eugenic problems are not immediately urgent as the pessimists believe them to be, their ultimate importance can hardly be underestimated. And in the same genetics, so this is end quote. And in the same genetics textbook, we see Stern link the ideology of eugenics with the equally destructive ideology of ableism. Stern again states, and again, these are his words, not mine, quote, to state that the reproductive selection against severe physical and mental abnormalities will reduce the number of the affected from one generation to the next by only a small percentage does not alter the fact that the small percentage may represent tens of thousands of persons. Conversely, even a slight increase of desirable genotypes through progressive eugenic measures would be a social gain, end quote. And what Stern and many other geneticists who were active until the 1970s and 80s believed was that so-called eugenic counseling should be used to identify individuals with sickle cell trait, hemophilia, and several other conditions, and ensure that they do not have children, either through quote unquote voluntary or involuntary sterilization, marriage restriction, or the use of social stigma to make social life for these individuals impossible. American eugenicists believed that a world free of disability could be achieved and that the most marginalized communities were the most harboring of the so-called deleterious genetic constitutions. Both within and outside the American South, African Americans were often labeled quote unquote feeble-minded using utterly arbitrary and often political criteria. Such racist constructions existed alongside racialized accounts of intellectual disability, as exemplified by the dehumanizing vocabulary used to describe trisomy 21 in the history of discussions of this condition. Because of the ubiquity and presentness still of scientific racism and eugenics, we must be open about its legacies and its continual harm. Only through meaningful dialogue with past and presently marginalized communities and the achievement of true equity in genetics and genomics research, in the genetics and genomics research community, will we be able to establish trust in the revolutionary benefits of genomic science. And as demonstrated by NHGRI's recent symposium on disability and genomics, contemporary genomics must not only continue to dialogue with disability communities about life-changing treatments, but also be frank about eugenic legacies, medicalization, and the ubiquity of exclusion and stigma. Through these and other efforts such as the NHGRI's TIDE office and the NIH's UNITE initiative, we can ensure that the potential of genomics is truly accessible for all. Thank you, and I look forward to your questions.
Thank you so much, Dr. Donohue, for that amazing commentary and comments, and also to Mr. Bonham for his recording. Thank you very much. We have a number of questions that have come through, so if it's okay, I'll jump right in with some of those. So the first question we have is, modern eugenics primarily an issue in the prenatal space?
In terms of sort of, I think it's what do you mean by eugenics? So I think that's a very difficult question to define, because we're really talking about what do you mean by eugenics in the context of sort of the clinical encounter, and in terms of a lot of the research has a significant number of worries about the use of prenatal screening and diagnosis, for example, in terms of the so-called diminution or elimination of some kinds of disability. For example, in the case of Denmark, where you have a screening for trisomy 1 or Down syndrome, there is a lot of worry that because of the virtual elimination of that condition in Denmark, because of universal screening for that condition and the associated social stigma associated with it, that it in fact sort of is tantamount or equivalent to eugenics in that case. But I also think that it's very important to think about eugenics more broadly as affecting many other communities in a variety of ways beyond sort of the prenatal situation or the infant situation, and thinking about eugenics in terms of just very broadly, sort of medical and social stigma. So I think I've answered your question, and I apologize if I haven't. But
no, I think that's great. I'm actually going to follow it up with one that's sort of related, because I think it's asking for a little bit of clarification. So it says, is a focus on the PGD and NIPT as agents of inequity based on these technologies not being available to underserved populations, or on the use of these technologies to limit outcomes of pregnancies to control the populations allowed to reproduce? So I think that first question was referring to that slide in Mr. Bonham's where he talks about the PGD and NIPT. So do you feel comfortable expanding on that at all?
I think in a general sense, I certainly think it's both. I think it's definitely ensuring that those technologies are widely available, with in terms of ensuring that those technologies are being used in a manner which emphasizes individual autonomy and respect, and with full equity considerations, and also in the sense that because of health access issues, and Kamisha Russell has talked about this, as has Dorothy Roberts, that in many ways genomic technologies are very much underserved in some fundamental ways, marginalized communities. And in fact, it's not simply the use of these technologies to say eliminate or diminish disability, but also just making sure that these communities have access to all of these revolutionary tools so that they can essentially integrate this into their lives and make full autonomous choices with the maximum amount of information and the maximum amount of care. Is that a sufficient answer? I think it's definitely both.
I appreciate that. I think that's helpful. We have another question that says, this is a very thought-provoking and completely agree with every point. How could providers discuss things with individuals and families from a population clearly at more risk for some diseases? And the example that's shared here is the Ashkenazi Jewish population.
So that's a fantastic question. And I think in that case, it's often the experience has been that individuals who are part of that group often have a great deal of information that they bring to the clinician, they bring to the physician, they bring to the clinical encounter. So it's really just a question of making sure that individuals in that group are at higher incidence. That it's a statistical discussion, but also, and that those conditions don't define them or don't define their clinical encounter, and also just be, mindful of the fact that it needs to be, in many senses, equity is a dialogue. So there's the physician knowledge and the patient knowledge, and multiple understandings of a condition, multiple understandings of its history and its significance. This is not simply with Ashkenazi Jewish groups and populations, but with other populations as well, with similar sort of incidences of conditions that have sort of higher incidence or higher frequency. But I think it really just needs to be a dialogue in which clinicians and practitioners are open to multiple sort of understandings and interpretation, and not really reducing an individual or a group to one condition or one encounter or one sort of set of sort of clinical understandings, but really being open to many other things.
I love that. It is a discussion and a conversation. So thank you for highlighting that. And we have another question here. As our knowledge and sensitivity to the impact of race and health equity grows, do you foresee more patient workups not taking into account a patient's ethnicity? And could this, not intentionally, but potentially, cause future harm?
So I think as a historian, that's a bit of a difficult question for me to answer. I would say that as a general rule, that races are not real, but they are real in their consequences. They're real in their social and political consequences. And I think we just have to be very careful of making sure that we take all of our have an ability and I have an understanding that all of the more knowledge that we have in dialogue with the patient, the better, so far as that it's an equal discussion that really doesn't reduce a patient to any group or label or characteristic. And again, it's an equitable sort of dialogue discussion, but that's a little bit outside of my expertise, but thank you.
No worries. And I appreciate that. And we do have a request for if you could share some of the resources that you were reading from. I don't know if that's a possibility. After the fact, we could post that or share that with the attendees.
Yeah.
There is a question also, in addition to hiring a more diverse care team, what can we do in the community or in practice to dispel these myths, especially since patients may not seek healthcare due to mistrust that previous healthcare has created?
Right. So I'm gonna speak specifically to my expertise in the disability space. I think a lot of the discussions around health equity that we're having right now are really around the fundamental notion of disability, which is our audience knows, that this audience knows, it really affects other marginalized communities at higher incidence at the same time. So it really is a question of access. And it really is a question of making as many accommodations as you can, particularly in the context of disability or any other kind of marginalization, and that to really be very careful and consistent, and to not necessarily making sure that you see the person, that you just don't see the condition, and that you're able to really ensure that as much as possible you make the clinic or the clinical encounter a welcoming space, because it really is about health access and health engagement. And for many individuals, that's not possible for one reason or another. And I think that's the key.
Great. And while you're speaking about that, you said your expertise in disability, and I know that you were part, or I think led, that workshop that was done. Do you want to expand on that just a little bit? I know Mr. Bonham referred to that and said, so I attended some of that, and I thought it was really, really thought-provoking. So do you want to maybe give a plug for that, where people can find that?
Sure. And so this is where we had a 2-day symposium on disability ableism and its complex connections with not only the history of eugenics, but the modern health sciences, including genetics and genomics. And I think what we really wanted to do with the symposium, the fundamental goal, was to really underscore that eugenic legacies are very much operating in the space of disability in medicine, and at the same time underscore that disabled individuals, particularly in the clinical context, are oftentimes alienated and reduced to their condition, or reduced to a specific characteristic, where there's a lot of scholarship that really underscores how in many ways the reduction of disabled individuals in a medical and clinical context is really harmful and actually leads to adverse health outcomes. So we provided a number of really path-breaking scholars to really look at the history, not only the history of disability and ableism in the context of genetics, but also look at very contemporary issues. For example, adverse outcomes with individuals with trisomy 21 because of the reduction of trisomy 21 and COVID outcomes to biological factors, when in fact social determinants are much more important. So it was a mixture of history and current research to really open up the conversation about disability and genetics and genomics at the NIH. Which we are continuing.
And where can people find that if they want to? Because I think it was recorded, correct? They can go back.
Yes, it's on our Genome. It's on our Genome TV YouTube. It actually should be up shortly. And actually, when we post the conference and symposium proceedings, I guess we should also send you an email, because it's not up quite yet, because it just happened about a month ago. So we can follow up about that.
Perfect. So coming soon.
Coming soon. Yes, I should say.
And here's a historical question for you, since that's also your expertise. Have there been any efforts to review common genetics healthcare textbooks, historical textbooks, to correct misinformation, such as certain races having higher pain tolerances? And then the textbooks you mentioned about 1973. Do you know of any efforts of that?
So no, and actually this is an area of research that I'm actively engaging in because it turns out that there was really dehumanizing vocabulary, particularly around intellectual disability and developmental delay and chromosomal conditions in medical genetics textbooks up through the 1980s, at least until 1982. And there has not been a systematic effort to review these resources, and I because of that, there hasn't been, I don't believe, a systematic effort to sort of come to terms with those legacies, because in many instances there are folks who were trained with those textbooks. So to answer the question, I'm actually doing that investigation, but there has not been sort of an effort, a systematic effort to address it because the knowledge is not there. But I want to point folks to the participants here to work by Andrew Hogan, who's at Creighton, who actually looks at the history of genetic understandings of developmental disability, who's a brilliant historian, and I would certainly point you to Andrew's work, Andrew Hogan.
Wonderful. Thank you so much.